My name is Dr. Sommer Hammoud. Thank you guys for coming. I'm one of the sports medicine surgeons here at the Rothman Institute. I specialize mainly in reconstructive surgery of the knee. It involves ligament reconstructions, tendon repairs, meniscus treatment, meniscus tear treatment, cartilage repair types of treatment. I don't do any knee replacement or hip replacement surgery. My arthroplasty colleagues do that. I do everything kind of to try to avoid that, basically, if you're a candidate to try to avoid the hip and knee replacement. I'm the director of our female athlete program here at the Rothman Institute. And tonight we're just going to talk about some common knee injuries. Just based on the group that's here right now, certainly none of us are in college. So I'm going to direct and probably not talk about some of the things that really apply to the younger patient population, which the high school and college athletes. And so we'll focus more on things that happen in a slightly older patient population, okay? The first thing I want to talk about is the most common, okay? So meniscus tears, okay? So probably some of you have meniscus tears and you may or may not know it. So meniscus tears, believe it or not, 60% of the population over 60 have meniscus tears and have no pain. They're walking around, they're living life, and they're totally normal. So they're just like arthritis. They increase with age. In some people, they're problematic and they cause pain. In other people, they don't, okay? We only care about them if they're causing pain. Now, the problem is as you get older, we also know that the rate of arthritis increases. And to differentiate the two, the meniscus tear is the cartilage that sits in between the ends of the bones. It's a C-shaped structure. It's made of slightly different cartilage than the type of cartilage that caps the ends of the bones, okay? That's your cushion or your shock absorber. You need the meniscus in order to not have arthritis. However, arthritis can develop even if you have, believe it or not, no meniscus tear. Now, the challenge as people get meniscus tears as they get older is that the arthritis increases. And when I say arthritis, I refer to the cartilage that caps the ends of the bones, the end of the femur and the top of the tibia. And just like tire threads on a tire, they wear out with time. The cartilage on the ends of our bones also thin out and wear out with time. And so when I refer to arthritis, I refer to the thinning of the cartilage at the ends of the bones and the pain that results from that. Ultimately, I'm sure you've all heard the term bone-on-bone arthritis. That is the end result of all the cartilage wearing thin, okay? And essentially, you have no more cushion, and the bone is resting on the opposite bone. Now, arthritis is also one of those things. Some people have very severe arthritis when you look at it on an x-ray. They're bone-on-bone, but they don't have pain. Again, that's not a problem. If you don't have pain, but you have arthritis, no one wants to do any sort of surgery on you. The only time we care about arthritis or meniscus tears is when there's pain that accompanies it. When you have a meniscus tear, however, and when you stand up and you get an x-ray taken, we call those weight-bearing x-rays. If you're at your doctor's office, if you're going to get your knee checked out and you're not in an orthopedist's office, you always want to ask your doctor to take x-rays of your knee when you're standing up. The reason for that is that's actually the way we diagnose arthritis. And we diagnose it based on the space that's left between the bones. There's usually this black, all we can see on an x-ray is bone. We can't see cartilage, we can't see meniscus, we can't see ligament, tendons, we can't see any of that stuff. So all we see is the space that's left between the bone. And as the bones approach each other and they get to less than 3 millimeters of space left when you're standing up and getting an x-ray, even if you have a meniscus tear, getting an arthroscopic surgery to treat the meniscus tear is not worthwhile. I would never recommend it because it's probably not going to do you any good. You're still going to have pain because ultimately the arthritis is the problem. And that ultimately needs some sort of knee replacement. Okay? Now, if you don't have a lot of arthritis, irrespective of your age, so you could be 80 years old and not have a lick of arthritis and have a meniscus tear. A meniscus tear typically results in a kind of The more traumatic ways of it tearing, one, you could be doing a squat and be getting up from that squat or have a twisting event. Those are the types of things that tear your meniscus. You may or may not hear or feel a pop that happens at the same time. It's typically accompanied with swelling in the knee, but not always. And more often than not, people complain of pain either on the inner joint line or the outer joint line where the meniscus is. It's typically not pain all over. It's very specific. The patient will almost always point right there, say, "Doc, it hurts me right there," or "It hurts me right out here." It typically hurts more when you bend your knee, okay? And it also typically hurts more when you twist or pivot or you do lateral movements. Now, if you don't have a lot of arthritis and you have a meniscus tear, usually x-rays are the first line. If you don't have a lot of arthritis, typically an MRI is then ordered, and that will diagnose the meniscus tear. And like I said, 60% of the population over 60, they don't have pain, even though they have meniscus tears. So almost always we try some initial conservative treatment, meaning we may give you cortisone injection, use ice, use anti-inflammatories like ibuprofen, Advil, and Aleve, do physical therapy, any different measures to help reduce the symptoms. And oftentimes, over about a 6 to 8 week course, that pain from the meniscus tear will go away. If it goes away, then great. You don't need anything else done. If you have persistent pain and it's bothering you and you're a candidate for arthroscopic knee surgery, which is surgery done through 2 small incisions in the front of the knee, then that's an option on the table for you. But again, that's elective surgery. It's not necessary. If you want to live with the pain, that's also okay to do. Okay? Anyone have specific questions on that? It's a lot of information.
You don't have, you don't have a diagram of it.
Don't. Do you guys, can you see if there's a model in one of the pods?
How does exercise affect 6 arthritis?
So physical therapy?
Like, can you still ride a bike? Can you swim?
So the question is, how does exercise either factor in once you've been diagnosed with arthritis or a meniscus tear, and maybe how does it help solve that? So the bottom line is, if you have a meniscus tear and or if you have arthritis as well, the bottom line is you do what you can tolerate, okay? So say you're running, you're a jogger, and it really doesn't bother you when you jog, then by all means keep jogging. Because the first and foremost thing that helps minimize your need for a knee replacement or minimize your risk for needing a knee replacement at some point is to be thin. Weight is the biggest factor involved because your knee and the joint surfaces, the cartilage, sees 5 times your body weight. So the thinner you are, the better off you are, and the more likely it is that you will not need a knee replacement, although it's not a definite by any means, okay? But the one thing that you have in your control is weight loss. The one thing you have in your control or in my control to help you is you losing weight, okay? So that's by far the most important thing. So staying active is important. So you essentially do the thing that doesn't bother you. Now, some of the things that work best are walking, not on hills. Typically, if you walk hills, it's going to hurt. Level ground, swimming, and riding a stationary bicycle or a regular bike. Now, if it doesn't bother you to do more, by all means, you can do more. You go based on your symptoms, basically. Yeah. The benefit of doing physical therapy or exercising in eliminating the pain from meniscus tear or arthritis is the idea that if you strengthen the muscles around the knee joint, if you strengthen your hip, your butt muscles, your core, it takes the pressure off of the joint surfaces. And that's the way physical therapy and exercise in general help to minimize pain. Okay? So this is essentially what a joint looks like. The meniscus is the C-shaped structure. You have a medial and a lateral or an inner and an outer, and they're the cushion inside your knee. This picture is a picture of moderate arthritis where you see the cartilage that caps the ends of the bones is starting to wear. And this is more severe arthritis where you have areas of exposed bone on the surface. So you guys can pass this around and take a look at it.
I have a question.
Yes.
Do you recommend supplements like glucosamine or chondroitin for
So
keeping your joints?
The question is, do glucosamine and chondroitin sulfate help? To be fair, there's no overwhelming evidence to show that they help. They are expensive pills to buy, so it is expensive to maintain them. There is no harm in taking them, but I wouldn't necessarily recommend that you buy and spend the money on them because there's just no real proven benefit. Yeah.
About these six.
No, there's nothing scientific in terms of studies that have shown any real correlation between taking those supplements and having any limitation in your arthritis.
What about the Bengay and the rubs?
Yeah, so what about Bengay and other kind of treatment modalities? I say if it works, use it. Try it. If it works, use it. There is no harm. So something that no one really asked about, what about braces? Okay, so the only real braces, so there's on the one hand, a brace kind of treats your mind a little bit. It makes you feel a little bit more secure. So wearing one of those like little knee sleeves or neoprene, the kind of wetsuit material, okay? If it makes you feel better, then great, okay? Now then there's the other thing of a more mechanical benefit to a brace. So say you have mainly arthritis on the inner side of the knee and you're a little bow-legged, okay? Now, when that happens, your mechanical pressure throughout your knee joint actually changes, okay? So as you become more and more bow-legged because you're getting more and more arthritis on the inner side of the knee, the mechanical pressure from the hip down to the foot actually starts to ride more in the medial side of the knee or the inner side of the knee where most of the arthritis is. So you're using a brace called an unloader brace, for instance, which actually moves to push your knee more into a straight up and down position. That type of brace actually can offload. We call it an unloader brace because it offloads the area of the knee that's painful from the arthritis. So when you have isolated arthritis, either on the inner side or the outer side, the unloader braces actually can be quite beneficial because they mechanically unload the area of the knee that bothers you. So you use them when you're walking and doing weight-bearing activities, and they really can provide relief. Obviously, that relief is there only when the brace is on. It provides no permanent correction. But again, once you're diagnosed with arthritis and your only real surgical option is a knee replacement, at that point it becomes symptom management. Trying to control your symptoms to try and avoid the knee replacement, basically. Or to get you to a state where you're comfortable again and you don't need the unloader brace or the injections or the therapy. You know, you're kind of at the steady state of, hey, I'm good, I'm comfortable, I'm not in a lot of pain.
And what about the injections, the ones that are done with 4 weeks?
Yeah, so the Orthovis, they're called hyaluronic acid injections, and there is some benefit to those. I would say it's a little bit better than 50-50, you know. It's better than cortisone in that multiple or repeated cortisone injections can be detrimental to the healthy cartilage in your knee. Getting one every few months or so, particularly if you already have severe arthritis, when I'm talking about cortisone, that to me is no problem. You know, every 4 months or so getting a cortisone injection. If your next step is a knee replacement, I say get the cortisone injections if they work for you, okay, until they don't work for you anymore, okay? Now, those injections, those don't have that same detrimental effect of cortisone, which can be harmful to the healthy cartilage cells. Those are given as a series of injections. In my patients, I would say they help more than they don't help. The worst thing is that just you end the series and, you know, you don't really have any pain relief. There's no real damage that's done to the joint. Those can be repeated every 6 months. The reason the 6-month time frame is because insurance typically won't reauthorize it for another 6 months. They're very expensive injections to get without insurance. So if people find benefit with them, we typically repeat them in 6 months or at the time interval that their knee starts to hurt again, which can sometimes be like a year later or 2 years later, whenever it bothers them.
What's the name of the injection again?
They're called, the general term is hyaluronic acid injections, but the specific ones that we, kind of our preferred one here is called Orthovisc. We tend to prefer the ones that are given as a series of 3 or 4 injections, depending on what your insurance will authorize, as opposed to the one that's given as a single shot. The reason for that is that the one that's given as a single shot can sometimes have an inflammatory reaction where the knee gets very swollen, gets very painful, and that's minimized with the injections that are given more as a series. Yeah.
Why when the humidity makes the,
I don't know. The question is, why does weather changes or humidity cause more pain in the knee? It's a mystery to me. I don't have the answer for you, but it's very common. This happens in people, anyone who's had a broken bone, even anyone who has hardware like metal plate and screws. Even people who just young patient who's had ACL surgery, maybe they've had meniscus tear, that meniscus was fixed. They tend to also say that they feel something in their knee. It's not necessarily severe pain, but they get a sensation in their knee when the weather changes or the humidity. So it's more of a phenomenon of an injury that previously occurred or having had surgery than it is anything else, you know? Yeah.
So I want to do exercises to strengthen the
Mhm.
knee.
Yeah.
What would you recommend types of exercises?
Yeah, so in terms of, I recommend, it's very important to do core strengthening. People ignore everything kind of upstream of the knee joint, which is really important. Core strengthening is really important. Hip abductor and butt strengthening is very important. So side leg lifts, okay? So the hip abductors, the machines at the gym that go out and that go in, it's very important to strengthen those muscles. And quad strengthening. I do think it's important to avoid repetitive squats and lunges when you have kind of knee pain. It typically is not going to help you. It's going to do more harm than good. I also don't recommend doing the exercise that has the knee extension exercise where the bar is here and you kick out.
Right.
It puts a lot of kind of compensated pressure on the undersurface of the kneecap and can become very painful. I think the better exercise to do is a leg press.
Yes.
Where your foot is planted on the plate. The reason why that's better is because you get a co-contraction of your quads and your hamstrings, and it minimizes the shear stress across your joint. So it's more of a balanced force across your knee joint. So it puts the least stress across the knee.
Mm-hmm.
I recommend only going to 90 degrees and going back out. I would avoid the deep knee kind of bending and exercises. Leg lifts, straight and also on your side, very helpful, and they don't put a lot of stress on your knee.
about yoga?
No, go right ahead.
I'm sorry?
Doing yoga.
Oh, yoga's great. Why not? Keeps you flexible. Yeah.
So with the exercising, if I'm not bending the knee joint, that's preferred as to doing an exercise that bends the knee joint.
It is. It will definitely minimize your pain to do an exercise where your knee is straight. So like a leg lift, a straight leg lift, or a side lift, it's not going to put that strain across your knee joint. That's for sure. But bending exercises are okay. So, you know, like the leg press, I would just tailor it to the leg press machine and avoid the knee extension where you're kicking out. And avoid kind of repetitive lunges and squats. They just tend to cause more harm than good. Any other questions on that? No? So I'll talk about another injury, which also happens kind of in the slightly older population, I would say 40s and up, okay? Does everyone kind of fall in that category? Is anyone younger than 40? You? Younger than 40 with bandana? You're older than 40? Okay. So I want to tailor it to the population, okay? So I'm avoiding the things that typically happen in the high school and college, you know, kind of 30-year-old population. So something else that happens, and it's almost exclusively seen in the 40 and up population, are tendon ruptures of the patellar tendon and the quad tendon. So those are also on that knee model. Actually, they're not. The patella's off of that. There's no knee model back there, really?
It's a joint.
Really?
I can check the other
Oh, that's surprising. We usually have them. So your quadriceps muscle, the quadriceps tendon attaches into the kneecap, and then from the kneecap down to the tibia is your patellar tendon. That whole mechanism together is called the extensor mechanism. Typically, those tendons tear at where they attach. There you go. So your quad tendon attaches to the kneecap. Your patellar tendon attaches to the tibial tubercle or the tibia. This that prominence in the front of your knee on that on the shin bone. So patellar tendon ruptures. The most classic story is a middle-aged guy playing basketball, went to make a jump, and his knee, he just didn't go anywhere. And the knee just kind of gave out. Or went to kind of stop something called an eccentric contraction to the knee, where you're going to stop yourself, like slipping on ice, which is very relevant because we're coming on the winter season. You're going to slip, your knee is bending, but you're trying to stop yourself, so you're contracting your quad. So this muscle is lengthening as it's contracting. That's called eccentric contraction. That's how those tendons rupture. It's almost always the way, okay? So a patellar tendon rupture and or quad tendon rupture, which again, the ways that they injure are very, very similar. A fall on a bent knee can rupture one of those tendons as well. So these happen actually a lot in the winter because of the ice. Typically, you'll have immediate swelling, immediate pain. Once one of those tendons is torn and not attached to the kneecap, you will not be able to walk normally. The knee will buckle because that muscle is no longer attached to keep you upright, okay? You will not be able to kick your knee out straight typically. You won't be able to lock it straight and lift it up because all that whole structure, this is what allows you to do that. Once there's discontinuity, you can't do it anymore. So those are almost an absolute. Unless you're very old and you're very sick, we're fixing it, okay? And we like to get to them quickly because if you leave it for a long time, the tendon starts to retract away from the bone and it loses that elasticity to pull it back and reattach it to the bone. So we actually like to get to them within the first 2 weeks if possible. So if you have anything like that, a fall, a slip, you may not fall even, but you slipped, but you felt or heard a pop and you really can't walk on your leg, it feels unstable, you can't straighten it, you want to come in for an evaluation right away. The diagnosis can actually be made on physical examination alone. Typically, you'll feel like a defect. So you can kind of run your finger along, feel the tendon, and then all of a sudden it just drops. There's just a gap, okay? And that can happen kind of above the kneecap or below the kneecap. You can feel that gap. And really the hallmark in addition to that is that inability to do something called a straight leg raise or lock your knee straight and lift it up, okay? So those are important to be aware of just because they are more common than you think. The quad tendon rupture is more common than the patellar tendon rupture. They do need to be treated pretty much immediately. So something to keep in mind. The other ligament, so those are tendons, okay, because tendons connect muscle to bone. So those are tendons. We have 4 ligaments in our knee. We have the struts on the inside and outside, the medial collateral ligament, the lateral collateral ligament, okay? They prevent the knee from moving this way and that way respectively, okay? Then you have the 2 ligaments in the center of your knee called the ACL and the PCL, and they're called cruciate ligaments because they cross in the center of the knee. And those control rotation as well as front-back position of the bones in the knee, okay? So most of you, if you were to sustain a singular injury of your ACL, your PCL, your LCL, we're going to treat it conservatively. We're not going to think of surgery typically, okay? Or we're at least going to try to rehab you and see if you do well without surgery. The most common, though, of them, okay, is the MCL. The MCL is a very commonly sprained, and it happens, again, because of the winters coming up, all that needs to happen is your knee goes out like that from underneath you, and you get this kind of inward buckling of the knee, and it puts strain on here, okay? It hurts typically on the inside. It's not always associated with swelling, so typically it's mostly just pain, but no real significant swelling that you would see as with an ACL tear or a PCL tear that's inside the knee joint, okay? It almost always hurts. People point to the inside, and it almost always tears off its attachment up here at the femur, okay? That's a good thing. 95% of the time it tears off its attachment at the femur because there's a very good blood supply there, and they almost always heal without surgical intervention. You may need to wear a brace for about 6 weeks to allow it to heal without kind of re-stressing it, okay, depending on the degree of the injury. Usually we need physical therapy because as it's healing back down, the knee starts to get tight with bending. So we usually do physical therapy and follow you just for the first 6 weeks to make sure you get your motion back, okay, and that you don't get stiff, because some people can get stiff with this. If it tears off the tibia and it pops all the way off and it curls up, believe it or not, that typically needs surgery. Now, it depends your activity level, your age, your degree of arthritis, but the problem is once it peels off the tibia, there are hamstring tendons that lie on top of it, and if it pulls out and outside of those tendons, there is no potential for that to heal. So a lot of times it's easier to just go in there and repair it back down to bone, because if it doesn't heal and 3 months have gone by and the knee feels unstable and it's buckling, at that point, there's no real opportunity to do a direct repair because that ligament tissue has shriveled up and you can't really pull it back to the appropriate position. So at that point, we typically need to do a reconstruction and take cadaver tissue and put it down. That's a much bigger surgery. So depending on the patient, depending on what the knee looks like, how unstable it is, sometimes we do go after those early on. That is also something that needs to be addressed in those first couple of weeks, because beyond that, the ligament tissue just retracts too much. It becomes very difficult to get any sort of repair. I would say those are the most common things, you know, that you guys would be dealing with in terms of knee pain by far. ACL tears, they happen, you know, but more often than not, you don't need to treat them. I treat a lot of, you know, women who get ACL injuries when they're skiing. Treat it conservatively. As long as you're not unstable after physical therapy for 6 to 8 weeks, I let them get back to skiing. They do very well. So it just depends on how unstable you are after an initial course of physical therapy. And how, you know, again, it always comes back to how much arthritis do you have, because once you have severe arthritis, these other ligament tears almost become a non-issue, you know.
What about canes? Using canes?
Canes are great. Cane, the one problem I see, it's a very, very common mistake. People always put it in the same hand as the injured knee. It should go in the opposite hand. Okay? I find canes are much easier for a patient like you than crutches. Crutches become very difficult. I don't even think I could stand crutches for a week, you know? They're very hard to get around with. So a cane tends to be much better if you can tolerate some weight on your knee. But always use it in the opposite hand, because you want to keep walking normal with the opposite hand and leg going forward at the same time. You don't want to go same hand, same knee, which is a very awkward way of walking. So when you go forward with the opposite hand, you put the pressure on the cane instead of the knee that hurts. Okay? What other questions? Do you guys want to see this model?
Okay, one more. When do you know you need a cane?
Oh, it's when do you know you need a cane? Same thing as your other questions. You use it if you're limping around, like when the pain warrants it, or you feel you're really limping because you're in pain. It's much better to use a cane than to limp around on a bent knee, because that's actually going to not allow that knee to start to feel better, you know? I always tell my patients, continue to use your cane or crutch until you're walking more normally. When people are limping, I always prefer that they use some sort of assistive device like a cane or crutch, because it's just not good to walk around on a bent knee.
So taking something like the anti-inflammatory, I mean, is that worthwhile if the real issue is the bone and the tissue? Is, cutting back on the irritation, inflammation worthwhile?
Yes, because that's what the issue is. The issue is the pain, right? That's why we're here as surgeons and doctors to give our patients better quality of life. Better quality of life means more functional use of their knee joint, right? Or hip joint or whatever it is that we're treating. And it means less pain. That's what we do. So anything that we're going to recommend to you is typically to help alleviate pain and or improve function. So when there's something as simple as an ibuprofen or an Advil that can help minimize your pain and you take it when you need it, why not? Why not that as opposed to some sort of surgery or something, you know? To me, that's a much better alternative. Now remember, as we get older, the linings in the stomach don't tolerate anti-inflammatories as well. So you do have to be careful. You really have to limit your use. If you've ever had a GI bleed, if you had some sort of anti-inflammatory like ibuprofen, Advil, Motrin, then it's better not to take it. Once you're above the age of 70, you really got to be careful because they really can wreak havoc on your stomach. If you've had any kidney issues in the past, you want to avoid it.
What about Tylenol?
Tylenol is metabolized through your liver. So while Tylenol is good as well, so if you can't take an anti-inflammatory because of stomach pain or whatever, Tylenol is the next best thing. It's not as effective as the anti-inflammatories, but it's also a very good option. If you've had liver issues, hepatitis, anything like that, cirrhosis, any of those diagnoses, you want to avoid Tylenol. You also have to watch how much Tylenol you take in a day. So I would say for all of you, you shouldn't exceed 3,000 milligrams in a day or 3 grams of Tylenol in a day. Because again, of the effect it can have on your liver. So you got to be careful if you're ever prescribed like Percocet, Norco, Vicodin, all of those have Tylenol in them, so you have to be cautious.
So how much of the others, the ibuprofens, would you, if you have not had a problem with
If you have not, I would just follow the label. Yeah.
Slightly different issue for me, and your advice is welcome. I'm a spinning instructor, and a lot of repetitive motion.
Yep.
But great if you have arthritis, low impact, and keeps the fluids in the joint quite active. For a period of several months, I was beginning to experience some pain along this corridor here. And one of the trainers diagnosed, well, you've got an iliotibial band issue going on. So I did the foam rolling.
Yep.
And it alleviated it for a while, but then started to come back. Was noted by one of the other instructors, my mechanics was a little off. The right knee was flopping out a little bit, concentrating on having a little bit of mechanics. That seemed to work too. And then came back, went to wearing one of the neoprene braces, and that helped some too. Then one of the trainers suggested, look to your hip. And I started doing some intensive hip exercise on that side, cleared it up completely, got rid of the brace. Well, 2 weeks ago, I was doing a very vigorous spin, felt great, and then simply went to get off of the bike and then tweaked something. Didn't get better for a few days. And I thought, well, I looked at the knee diagram, so I got to be a little more familiar with your business here. And I thought it was going to be the collateral fibular ligament that finally broke down. Went and saw one of your colleagues here in family medicine, and she said, "No, it's your IT band." Yeah, it was feeling so good, and no, it's right. Did a physical examination, brought any real acute pain down with naproxen, and that was all fine and good. And been doing some very light stretching with it, and it's feeling pretty decent 2 weeks out. But you know, I'm ready to get back to it. Would you recommend the knee brace as a potential?
Just maintenance of all the exercises and the stretching that you've been doing.
Okay.
That's really the main thing. Yeah.
So the
Braces just aren't really helpful for IT band syndrome.
Yeah.
Yeah. Again, I remember I talked about the braces for two different things. If it does make you feel better,
Psychological.
yeah, then use it.
Right.
Who cares? Yeah. Like if it makes you feel more secure or it reminds you to be a little bit more cautious with your
Right.
knee, why not? No big deal.
Yeah.
But it's mechanically not going to do anything necessarily to make that pain, you know. Yeah.
It was I guess, category 1 sprain, maybe a little more severe category 1. Based on your experience and, you know, age cognizant, 3 weeks minimum before I'm back.
Based on your symptoms.
This
Go
based
based on your symptoms. Yeah.
Okay.
If you're feeling better, go for it.
All right.
Yeah.
How did you get diagnosed that was an IT band?
Well, the doctor in family medicine here, I explained the symptoms, and my diagnosis as a very poor secondhand doctor, and she disagreed. Didn't think it was the anterior fibular ligament. She said, it's your IT band. I go, gee, it was doing so well. And based on that physical examination and my progress up to that point, she didn't feel the need to send me off to Rothman.
Yeah.
And, you know, I'm feeling pretty darn good today. Yesterday, a little less so, and every day goes by, it's a bit better. It's a complicated thing, the knee.
It is, yes.
It's a wonderful thing. It's
So it was just a family medicine person
Yeah.
diagnosed?
Yeah.
It's not confusing. The family medicine are the non-operative sports medicine physicians. It's a family medicine person who specializes then in sports medicine. Just go see someone. Don't rack your brain. Just go see someone, let them make a diagnosis. They'll tell you what it definitely isn't, at least, and could give you the possibilities of what it is.
I was satisfied with her
Yeah.
examination and diagnosis. In fact, she was training an intern along with her, and it seemed thorough. She explained what it is and what it's not to me and the other person, and I felt comfortable that I was getting good care at the family medicine
When you
level.
say a family medicine, are you talking about general, like internal medicine?
Yeah. Well, those are the gatekeepers. I'm sure she would have sent me to you if she felt it was necessary.
You've already seen those people. I would just go see someone who specializes in sports medicine. Wherever you want. You can come here. We have great people, lots of people, but you don't have to. You know, you can go wherever you want.
I've had 2 diagnoses, which you
Just go see
suggest are
someone who
incorrect.
specializes in sports medicine and injuries around the knee. Yeah. That's it. Anyone else?
Does stretching around the knee area, does that help? And if it does, how does stretching help?
So stretching helps, again, for more specific diagnoses like IT band syndrome, it does help specifically solve that issue, okay? In general, staying limber, having good motion in your knee, stretching, making sure you maintain your motion is good in general, in that the better motion your knee has, when your knee becomes stiff, your mechanics are off and things start to become painful. And that's honestly the most simple way to put it. Yeah. But staying strong, making sure you maintain your stretching and your flexibility as much as I'm not really a flexible person, honestly, but maintaining it to as much an extent as you can, it just keeps things working, you know? All right.
Well, thank you.
Everyone good?
Yeah.
Dance after it.
Thank
All right,
you.
good. Thanks for coming, guys.
Thank
Okay.
you very much.
Take care.